Okay. I keep saying every time I think the bar has been elevated to as high as it can go, I'm surprised. Tonight we're going to talk about some techniques that absolutely have me in awe. We had neurosurgeon on that talked about brain surgery just being what they do routinely, and the spinal surgery is the real big thing. But tonight, sit back. The fact that this is being done is amazing. The fact it's being done here in the center of the universe at Milford is something that I can't say anything more than thankful. But why don't we start with an introduction?
Yeah, so my name is John Phillips. I'm a radiation oncologist. I work for the Brigham and Women's Dana-Farber Cancer Center, and I see patients out here at our Dana-Farber radiation oncology facility here in Milford.
Now, I just learned that we're getting $5+ million investment in a new toy, a new linear accelerator.
We like to think it's more than a toy. It's so the bread and butter of what we do is a machine called a linear accelerator. It's basically a machine capable of generating very high energy, very focused X-rays, and that's how we treat cancer with radiation 95% of the time in 2018.
Now, I asked Peter Oreo, and he wouldn't give me a straight answer.
Okay.
So I'll put you on the spot.
I probably shouldn't give you a straight answer either.
How did you go to Uncle Ed and say, oh, we'd like $5 to $10 million, and by the way, once you give it to us, we want to take part of the building out, so move the lab, and then once we move the lab, we'd like to take your office and your area out?
Yeah.
How did you get away with that?
I think that's a Peter Oreo sell right there. No, I think it's just what our patients needed, and I think that's the key thing. It is probably an easy sell once you really dive down into the numbers of it. We take care of a lot of folks out here in Milford, and a lot of folks want to get their care centralized here with the hospital and everything they can get done in the cancer center. We are literally bursting at the seams with patients, and being able to give patients timely appointments, being able to accommodate more patients, it all just sort of makes sense from our perspective.
Well, I was totally amazed when I heard we're already dealing with 50+ patients a day.
Yeah.
That's incredible.
No, it's the center celebrated its 10-year anniversary this year, and you never know when you move into an area if you're going to catch on, and it's a lot of investment, and it's a lot of time investment and people investment, and we could not be happier with our partnership with the folks out here in Milford. I think everybody at the Cancer Center the folks that work there love where they work.
Now, base level questions.
Sure.
What is it you really do, and why do you do it? You hear about, if I have cancer, I have the nuclear option. I can chemotherapy and blast everything that's fast growing.
Yeah.
I have radiation, which in the old days was take a blunderbuss and kind of irradiate big chunks.
Blunderbuss, I haven't heard that term in a while for sure.
But when I think about decades ago when radiation therapy first started, millimeters?
Yeah. It's a different game. I think I'm and Peter's from the same generation of radiation oncologists that came in after we really integrated computer technology and advanced imaging technology. So that happened around the mid 90s through about 2005. And what I do is I use advanced imaging, so CAT scans, PET scans, MRIs, and all kinds of variations of those to figure out where cancer is, where it could be, and then use high energy focused X-rays to destroy it. And that's what the essentials
walk me through.
are.
We start with an MRI, then you threaten to scan my cat, and then if that doesn't work, you scan all my pets.
Yep.
Why is that the logical progression, and what does each of them do?
So it all just depends on what part of the body you're dealing with, which one is useful, but they all give you a little bit different information. The CAT scan is key for what we do because radiation can't be designed without density. So CAT scans give you information on tissue density relative to water. And that sounds like a bunch of kind of strange physics stuff, but you have to have that to be able to do radiation. And then each of the other scans gives you a little bit something different. They each have a little flavor. So PET scans are about metabolism. A PET scan, we inject you with a radioactive sugar. And anything, there's parts of your body that take up that sugar normally. But
Stem cells?
The stem cell, your bone marrow, your brain, your heart, you excrete it through your kidneys. So all of those places light up normally. But most of your cells, they kind of take up a normal amount of sugar. But tumor cells love sugar, and they are going to eat it like crazy. So what a PET scan is we just inject sugar, but it has a little radio tracer on it. And whenever those cells eat the sugar, it breaks down that radio tracer. It gives off a little signal, says, hey, look over here, there might be something interesting. So when we do a PET scan, it really helps us find those areas where maybe you can't see anything there anatomically, but there might be something going on. An MRI really just shows us the anatomy in high definition. And so the MRI gives us one piece of information, the PET scan gives us another piece, the CAT scan gives us another piece. We don't always need all three, but oftentimes when you're in a difficult diagnosis situation or you're really trying to nail down what stage a patient is, having one, two, or all three can be really helpful.
So now, when I do a PET scan, I'm putting in some kind of imaging agent,
Yeah.
you know, a carbohydrate moiety.
Yeah.
Okay. How come the stem cells don't pick that up? They're hungry little buggers.
Oh, they do to some extent. So, you know, the PET isn't just light up or not light up. They really dial down to like actual numbers. So it's a scale. They call it the standard uptake value, but it basically, there's a scale of hotness on the PET scan.
So it's like a glucose uptake rate that we do in cell culture.
Exactly. No, it is exactly that. So the hotter something is, the more likely it is to be something bad.
So your experience, then, you can look at what's the dull light,
Yeah.
which is normal,
Exactly.
versus the hot light,
Yeah.
which took up an abnormal amount of glucose.
Yeah, no, that's exactly what it is. So we use the liver as a reference point. Your liver takes up a normal amount of that sugar, and it sort of sets the baseline for what the body does. Anything above the liver's uptake value, we think, nah, this deserves a second look. It doesn't always mean it's something abnormal, but it means it's something. So these PET scans, they don't tell us there's definitely something here. They just tell us, hey, you need to give this area a second glance.
So now, when do I choose to go to you and say, I'd like to be well done or medium rare, versus going to a chemical guy and say,
Yeah.
hit me? You know, basically, I think of chemo as just blasting anything that grows fast.
Well, I think that's traditional chemotherapy. I think in this age, we think the best care you can possibly get for cancer is multidisciplinary care. And what that means is seeing everybody from the start. Once the ship sets sail, once you actively do a treatment, whether it's surgery, radiation, or chemotherapy, you can't take it back. And so the most important thing before you embark on a cancer journey is to make sure that you know exactly what you're up against, exactly what your options are, and make a decision based on that. So we try to do everything in a multidisciplinary fashion. So when you get diagnosed with, say, prostate cancer, you don't just see a radiation doctor, you don't just see a urologist, you don't just see a chemo doctor, a medical oncologist, you see all three, sometimes in the same clinic, sometimes in separate visits, but then we all kind of huddle and discuss our patients so that you can make an informed decision, but also so that the doctors can kind of say, well, you know, maybe you saw something I didn't see, or maybe there's something different or something nuanced that your expertise tells us that my expertise doesn't.
But, you know, I think of surgery or radio treatment, I think of point specific.
Yeah.
When I think of chemo, I think more, okay, it's metastasized, it's spread, and I got lots of points that I can't just nuke everything. Is that kind of a safer?
I think that's the gist. So surgery and radiation, the radiation we do is local. There are versions of radiation that can kind of go a little bit everywhere, but those are not what we're generally talking about. But most of radiation is just like surgery, wherever you point the radiation, that's where you get treated, that's where you get side effects, but it doesn't go everywhere else in your body. Medical oncologists are sort of in this evolution phase where they used to be chemotherapy doctors, and chemotherapy is designed to kill cells. So it's designed to interrupt some part of the cell cycle and kill them. But it doesn't necessarily discriminate between cells. It maybe kills the ones that are growing fastest, the easiest, but it hits everything.
Well, the oncologist's going to hate me, but aren't they kind of balancing trying to kill the cancer a little faster than kill the patient?
Well, that's you know, if they give you enough of anything, that's what happens. But everything is tuned specifically for your disease, for your height, your weight, your blood volume. They go really, a lot goes into every chemotherapy dose. But really, what's exciting about the medical oncology world right now is how targeted the therapies are becoming. So what I was talking about is traditional chemotherapy, which is what we've had all the way back to Farber, all the way back to the early days of treating leukemia in the basement down in Longwood. But what they have now is these targeted therapies that either take advantage of a genetic mutation in a cancer or immunotherapies, which activate your body's immune system. They basically just tell your immune cells, hey, you know, don't worry about killing those cancer cells, go for it. And those therapies are starting to become more specific in the cells that they target. So they're able to kill cancer cells a little more discriminately. And I think that's really where the future of medical chemotherapy will always have a role, but these therapies, we always sort of in the back of our head talk about the silver bullet or the magic bullet.
Well, we're looking for the magical epitope.
Exactly.
That spot, if I target, I get all the cancers.
Right. And so that's not reality, but there's a version of that. And I think, you know, 30, 40 years from now, maybe sooner. It's always so hard to tell. The targeted therapies are going to become more and more targeted so that cancer, the way we're designed, is almost an inevitability if we live long enough. But we may be able to offer treatments that have very, very high effectiveness rates and very low side effects. We're already offering those in a lot of cases. We're just trying to expand the profile of diseases that we can do that in.
Well, now the new tools coming in. Mm-hmm. I mean, I joke about originally the radiation docs were using a blunderbuss.
That's not far off.
They held you up, they nuked, and you said medium well, please, or.
Right.
But that's not the case. You're not hitting me or hitting a big part of me anymore.
No, these machines nowadays, they're able, if you really kind of like stood under it, hopefully when it's off, but if you stood under it, what you'd see at the treatment head is that it has these little leaves, and the leaves can move in and out to configure the shape of the radiation beam that's coming out. And those leaves get all the way down to below a millimeter in some cases on these machines. So what we're talking about is being able to shape a radiation beam down to the millimeter, maybe even the sub-millimeter level. At the same time, the machines have onboard CAT scanners that have very, very high resolution imaging. And so you're able to put a beam, it doesn't matter if you can put a 1 millimeter beam out if you don't know where it's going, but with this technology, we're able to, the instant before we're turning the radiation beam on, confirm that whatever we're targeting, whether it's tumor or where a tumor used to be, is right dead center in the middle of that radiation beam. And we even have the technology now, while the radiation beam is going out, to image and look for the tumor using the radiation beam. So we're really able to not just deliver a very precise beam, but we are able to know where it is in space with very, very fine accuracy.
So now when I look at a tumor, we always think of it as a homogeneous bad guy.
Yeah.
You know, that it's just equally bad throughout.
Right.
But when I read, I hear that, or I read that there's different regions, some worse than the others.
Yeah.
So you're able to target the worst part of the tumor.
Yeah, so we, when we're aiming for, and again, this is all very disease specific, but we are able to do what we call dose painting, which is exactly what it sounds like, where we say, gosh, maybe this area is a little more worrisome, or maybe there's if you had surgery, everything looks pretty clear, but this area over here just looks like maybe I'm a little worried, I can't tell for sure. What we're able to do is we're able to give our normal radiation dose to the whole area that we're worried about. But that area that we're really concerned about, we can just brush an extra 10 or 20% of the radiation dose into that area. It usually doesn't increase the side effects, but it increases the effectiveness.
Now, is it the side effects you worry about? Because, if I got a tumor, nuke it.
Yeah.
Hit the whole thing. I don't want any part of it.
Yeah. It's all about where it lives. If a tumor's out in the middle of free space, say it's in the center of lung tissue is very resilient, and so if you zap a tumor in the middle of a sea of lung, you usually don't see much.
Hepatic cells can regenerate.
Yeah.
So I'm not going to be real worried if you zorch a little bit of the envelope.
Yep, and so the liver is another good example of sort of a free target, so to speak.
But if it's in my brain,
that's a different story.
If you ask my wife, she'll tell you I don't have many brain cells to sacrifice already.
Yep.
So now, to me, missing a little bit or overshooting would be more worrisome, I would think.
Yeah, so we, as a field of radiation oncology, we have a very robust experience of knowing what parts of your brain are exquisitely sensitive to that focused type of radiation. So we don't do it when it's pressed up against things like the nerve that is responsible for vision for the eye. We do it very gently when it's in the brain stem, the part of the brain that connects the thinking brain to the spinal cord. But for the most part, the brain itself is actually very resilient. Nerve tissue is pretty well developed and isn't growing very quickly, and so it's actually very insensitive for the most part to radiation.
My wife would tell you that would shut down many synapses, and I don't have that many connections.
There are parts of the brain that still remain, we call it plastic, but it means growing, changing, adapting to all the input that your brain gets all day long. There are parts of your brain that do that all the way through into our 80s and 90s. And even beyond. Most of our brain's pretty set once we're 30. Not exactly, but for the most part. And so we've even designed radiation now to avoid those parts of the brain that are still active and forming memories and all of those things to try to minimize the side effects from getting brain radiation.
Way back when Paul Revere was a surgeon, I remember looking at stereotactic frames, and it reminded me of something on Lost in Space.
Yeah.
That people went in and all of a sudden you had an erector set. Just that scared the heck out of me.
It's scary stuff. It absolutely was. So was exactly. So the origins of this stereotactic radiosurgery in the brain, it actually originated with a neurosurgeon, and for that, to make sure that you were in the right space, that you were still enough. They actually bolted a metal frame that attached to the radiation machine. That's how they started in the late 70s. That's not what we do now. So nowadays we use a special plastic that has Kevlar, the stuff they make bulletproof vests out of, woven into it. We heat it up in either a water bath or a little oven, and it becomes kind of almost like a gel.
Just like your skates, you're customizing it to the person.
Exactly, but this stuff, because it's got this Kevlar fiber woven into it, when it dries and when it cools down, it forms an extremely hard mask. And because of that, we're actually able to open up the entire mask portion of the face. So when patients are getting stereotactic radiosurgery nowadays, they're actually uncovered from the nose to the brow.
I'm awake for this?
You're awake, and you can see, you can breathe, you can look through. It's tight. It's not uncomfortable, but it's tight because we're aiming for 1 millimeter levels of precision.
And they don't look up at you and say, "John, don't miss."
No, they, it's relative to, and our neurosurgeons do amazing work. But anytime you make a cut and you go into the skull or go into any part, there's a recovery, there's an ICU stay, there's all of those things. This is, snap the mask on, snap the mask off, and you drive home.
So now, if I'm calling in, I mean, we've got the chemical guys.
Yeah.
I bring it down to layman's level, and the surgeons will hate me. But you have the oncologists,
Right.
the chemical guys. You have the knifer guys, the
Yeah.
people with the scalpels.
Right.
The scalpel people, to get to the tumor, they got to make a hole in my head, right?
And they got to go through whatever's between.
I mean, they got to cut through the skull.
Right.
The chemical guys don't, so that seems like a benefit, 1 point for them.
Right.
But you don't really have to
Right.
do it either.
Exactly. So we call it radiosurgery, but there's no cut, there's no knife, there's no scalpel. It just means that what we're doing is basically obliterating that little spot that we're aiming at. But there's no cut, there's no damage to the tissue on the way in that you would have if you were taking something out from deep inside the brain. And so we always say it's bloodless surgery, so to speak, but it's really something more than that. We can find tumors inside the brain that you could never find with a scalpel because they're so small, and to get to them would cause so much damage. And so we're able to treat things when they're 3 or 4 millimeters in size before they can ever become a problem.
Let me understand. Okay, so I do a PET scan, I light up. So inside my brain, there's some little light bulbs saying, pay attention to me.
So in the brain, it's usually an MRI. Your brain takes up too much of that sugar, so a PET unfortunately doesn't work.
The background will just blend you out. Okay, so I've got my MRI in these 3 areas. It's inside the brain.
Right.
So how do I get the electrons or neutrons, whatever you're firing, to go through and not kill the good tissue outside, but only kill the bad tissue in the middle?
Yeah, so the key is that we come in from an infinite number of angles. So what I mean by that is if me and you were both holding if I had one flashlight and I shined it on the floor or shined it here on the table, it would make one bright beam. And that's one way to brighten the table. But if I gave 100 of us a flashlight, but each of us only had a flashlight about 1% as strong, we could all shine it on that spot and get a light just as bright. That's how radiation works. So we come in from, the machine actually can move while it's delivering radiation. So the machine is actually delivering radiation from all different angles. We move the patient in space.
So it's the aggregate amount of energy?
Right.
Okay, that makes more sense. I'm trying to figure out, how do you drill through without making a long hole?
Cross-firing. So I think that's the easiest way to think of it, is the radiation crossfires on the tumor. So you have a little bit of dose coming in from each angle. It doesn't really damage the tissue to any significant amount on the way in. But when all the radiation beams are crossfiring on that one point in space,
one focal point, then
bang,
you heat it up and you can hit just that.
It's gone.
Now, you imply, or you're saying that, well, we move this. I remember when they first talked about $1.5 million for a Da Vinci.
Right.
Dr. Clone, they were saying, that's good toy.
Yeah.
And it's proven itself 100-fold over. But I was amazed at how they could move, within millimeters.
Right.
How do you do that?
Yeah, so it's a combination of using imaging to make sure patients are exactly in the right space, but the new machine actually has what's called a robotic couch. So instead of patients laying on a table that can just move, and it has to be manually moved in 3 dimensions, the robotic couch can actually move kind of in all dimensions, but it syncs up to the imaging. So if we put you on the table and we line up the imaging we do the day you're getting treated with the imaging we did from all the mapping that we've done, and say you're off by just a smidge, the computer can actually correct those 6-degree motions in sub-millimeter levels. And so it can move you in space to get you lined up so that the tumor is dead center.
But how do you keep me still? I mean, when they did my scan years ago, they put me in a torpedo tube.
Right.
And I had to kind of close my eyes and try and not think that I don't know if I have claustrophobia, but this is going to give me claustrophobia. I'm in a torpedo tube.
Right.
Okay, when I think of 1 millimeter,
Yeah.
I mean, I've just moved a millimeter without even moving.
Well, it depends on what part of the body we're in. For the brain, it's the mask. The mask can hold you in place down to the 1 millimeter. So that's why we're using that plastic Kevlar composite. That it's tight.
So, but it's a less intrusive
Right.
stereotactic frame.
Exactly.
The old days, I had the erector set that basically I couldn't move if I wanted to.
Right.
You're saying you're doing the same thing, only now it's just a little mask that does it.
Exactly.
Well, that feels better.
There's no way to hold people still without holding them still, but it keeps getting better, keeps getting gentler, keeps getting easier, and our patients, they're very happy with how easy it is, and the fact that you come in, you put the mask on, and when your treatment is done, it pops off and you're out the door.
Let me think, mask or bolts in my head? Okay,
Yeah. No, it's.
it seems easy enough, even I can understand that.
We always think, if you look at medicine 200 years ago, it seems like barbary. And that's always the nature of the game, is that we keep trying to make things easier, keep trying to make things gentler while still making them more effective.
Yeah, I mean, you look back at the Civil War movies.
Exactly. No anesthesia,
No
analgesics.
antibiotics.
Yeah.
God, how they save people.
Right. But that's what they used, what they had. We always say, we do what we know until we know better.
Now, years ago, there was always a concern that if I stay in Milford, am I getting the same level of care
Sure.
that I do on Binney Street?
Right.
If I go to the real Farber, am I getting different
Right.
treatment, different level of people from the Dana-Farber here in Milford? How would you answer that to people?
So I work for the Brigham Dana-Farber. I spend 1 day a week downtown at the Death Star at the main campus, and we conduct the folks that are staffing the cancer center out here. They are some of the best people in the world. They are conducting clinical trials in cancers and bringing them those clinical trials to Milford. So. I think that's one of the huge things that we've been able to do really since we've opened here, but in the last 4 or 5 years, we've really exploded our portfolio of clinical trials that are available to patients here. So not only can you get the highest quality of care, the same quality of care that you would get downtown, you can get access to the clinical trials that we have access to downtown. Because we have them open here. You've had Peter Oreo on, you've had some of my colleagues on. We're investigators on those trials. We have them open. We open every trial that we can.
Now, a lot of people don't understand what a clinical trial is.
Yeah.
And you look, you say, okay, and you talk about phase 1, phase 2, la, la, la.
Right.
And people are like, what does that mean? Why would I want to be a guinea pig?
Yeah.
Why would I want to be involved in a clinical trial?
Yeah, so I think that the thing people, I think a lot of people understand nowadays, the education around it's gotten better, is that clinical trials are never testing nothing versus something, and they're never testing a treatment that works and we know works versus a treatment that no one knows works. In general, the way clinical trials are designed nowadays is something we know works versus that same thing with a little something extra or a little change to it. And what we're always trying to do is we're trying to make cancer treatments safer, more effective, and less toxic. And so every trial we run is, can we reduce the dose of something? Can we take a drug away to try to make it just as effective but less toxic? Or can we add something to it? Or can we change a little something to make it more effective? And the clinical trials that we open, we don't open everything. It's not like there's some giant book of clinical trials that you come in and you look through till you find. We open the ones we think are going to benefit our patients the most, because clinical trials take millions of dollars to run. They require a lot of staff. Patients get a lot of care and attention on those trials. And so, it's the general perspective of almost all oncologists that the best care you can get is to participate in a clinical trial.
Now, when I think, again, the old days, clinical trials were, well, nothing we have has worked. We don't have anything to offer you, but there's this Hail Mary pass.
Yeah.
But what you're saying is, for your type of clinical trials that you're involved with, it's really just a tweak.
So the trials you're talking about do exist. There are cancers that we are not as good at as other cancers. And what we're trying to do is in cancers where we're really good at treating them, those are the ones we make the little tweaks on. And on the cancers that we're not as good at, where our treatments are not as effective or where they're especially toxic, that's the one where the treatments are big changes, where we're trying new things and trying to innovate. I always say that every cancer that we have a home run for now, we didn't have a home run for 10 years, 20 years, 30 years ago. And so in every cancer, we're eventually going to have that home run. And in those where we're really just not good at, that's where the home run Hail Mary clinical trials have a role.
It's like pancreatic cancer.
Right.
You hear that, and
yeah,
it seems like
it's one that we know so much more about in the last 10 years, and still it hasn't translated to treatments that result in better outcomes for patients. That's one that comes to mind, glioblastoma, the aggressive type of brain tumor that Senator McCain is dealing with, that Senator Kennedy dealt with. That's another one that we just haven't cracked the code for yet. But there are clinical trials, there are innovative things happening, and there will be a home run. We just don't know when.
we're just not there yet.
Exactly.
Now, when you talk about shaping,
Yeah.
I remember Peter Oreo talked about no longer do we just throw a hand grenade in and hope.
Right.
That he actually shaped the charge and went around certain areas. How do you do that? I mean, you're talking about the bed move or the table moving and syncing with the laser so that if I wiggle, what is actually happening when you're at the joystick?
Yeah, so what the machine can do now is it has a special device that it's attached to it that uses 3D infrared cameras that are mounted multiple places in the ceiling above the machine. And we know where you're supposed to be in three-dimensional space based on those mapping days that we did. And while you're on the machine, we track you in 3 dimensions using the infrared cameras, so we can actually see if you wiggle your nose or lift your head, things that you wouldn't be able to see with the naked eye necessarily. And it's actually able to tell us, hey, this person's out of alignment. Maybe turn the machine off, let them cough, let them scratch their nose, and then go back after it. So we're able to track people in 3 dimensions in real time, which is something that is new even within the last 3 or 4 years.
That's pretty amazing when you start thinking about 3D monitoring and syncing.
Right.
Monitoring I can understand.
Yeah.
IR tracking devices have been around a while, but then syncing that to a 1 millimeter laser,
right?
Pretty amazing.
Yeah, no, people are working on the technology to be able to use those 3D tracking devices to actually move the table while the beam is on, which is kind of an advance in radiation that's going to change a lot of treatments for patients that are having second and third cancer treatments. But it's amazing how technology developed for other applications can come into oncology and play huge roles in advancing our treatments.
Now, how long is the beam on?
So it depends on what type of treatment. For these stereotactic radiation treatments, we really are delivering 3 or 4 weeks of regular traditional radiation in a single shot. So it's on a little longer. A traditional radiation day, the beam is actually only on for maybe like a minute. Most of the time that you're spending in that radiation room is getting you lined up down to those really precise measurements.
But a minute's a long time.
It is, but we're coming in from a lot of different angles, and most of the radiation dose never reaches you.
Well, no, but I'm just trying to think. You're trying to get me to sit still for a minute?
Oh, yeah, a minute, you'd be amazed. I think one of the toughest procedures to stay still, at least that I think of, is our lung stereotactic radiation. So that's where we do the same thing we've been talking about doing in the brain, but we do it to small tumors in the lung. And for that, patients lay in what is essentially a big beanbag, where we've molded it around their body and their shoulders and vacuumed the air out of the beanbag so that it kind of forms like a soft cast. And they lay there, and they lay perfectly still, and they don't move. And you'd be amazed if you saw.
Wait a minute. I'm laying there.
Yep.
Okay, you've glued me in. I'm not moving.
Right.
How do you tell my lungs, stop breathing, don't move?
So we account for that. We don't rely on a picture version of a CAT scan. Our machines are actually able to do a movie version of a CAT scan, so we can see the whole range of motion of your lung tumor with your breathing cycle. And if you're a marathon runner and you breathe and your diaphragm moves big distances and makes your tumor move big distances, we have ways to account for that. So sometimes we'll put a little bit of pressure on patients' bellies. That little bit of pressure on your belly just makes you breathe a little shallower, makes the tumor move less. So all these little things.
So we've got Peter the farmer planting his seeds. Now we have John the sniper.
I'll put that up on my door. I don't know if people will find
I'm just trying to think.
that.
It's probably easier for one of these military snipers to take a shot at a mile than for you to hit within a millimeter.
It's all about technology and utilizing the technology correctly. So it's not just me. I have a tremendous team of radiation planners and radiation physicists and radiation therapists that all come together to design the radiation, figure out how to make the machine work correctly every day, and then get you on the table comfortably, safely, and get the treatment delivered each day. Not to mention our nurses who are fantastic, our front office staff. I mean, it really is. It's not one guy with a shingle on the door over there. It's, even when I'm there in the facility by myself,
But now
it's
walk
20
me
people.
through that. I assume my GP, my primary care physician refers me to you.
Right. Well, that's usually not how it goes, actually.
Okay. How do I get to you?
So we tend to be a little more downstream in the process. So for the most part, let's say for a patient with a new diagnosis of a small lung tumor, the way they would get into our system is typically their primary care physician or their pulmonologist, if they've been diagnosed with something like COPD or emphysema. They've ordered some sort of CAT scan or X-ray, either for screening, because we're doing more and more lung cancer screening nowadays, or because of symptoms, and they found something. Well, that usually brings in a referral to someone called a thoracic surgeon. And the thoracic surgeon figures out, should we just cut this out to figure out what it is, or should we put a needle in it under CT guidance to figure out what it is? Or should we go down the airway while you're asleep and snag a little piece of it? But that gives us a diagnosis. And then once that diagnosis is made, we typically convene the surgeon, the medical oncologist, and the radiation oncologist. So patients typically come to me once the diagnosis if it hasn't been made, it's almost made.
You have a bad actor in you. Now we got to deal with
Right.
Who's the best of the three of us? Do I cut it? Do I treat it with chemicals, or do I nuke it?
Right. And it varies from, it's all about the details. So some patients, they're young, healthy, well, they can sacrifice, a quarter of their lung or a small piece of their lung, something like that. They oftentimes get treated with surgery because we can always come in with radiation after the fact. For lung tumors, it's tricky to do surgery after we've given radiation to an area.
Why?
It causes a little bit of scarring in that area, and so when we come in, if a patient's very healthy or they have multiple spots, sometimes what we'll do is we'll take a coordinated attack where I partner with the surgeons. They say, this one's very easy for me to access, so I'll take this little piece out, but I can't get to this one.
Can't get to this one.
That's
You
deep
can get there
by
with
a
your
blood vessel, so you'll radiate that. That way we're mixing the modalities so that the side effects from any one type of treatment don't accumulate for you. So it's all about the nuance to figure out who goes where. And then sometimes it's just patient preference. Some people, you know, they want to get it out, and they're eager to undergo the surgeon knife. That's totally reasonable. Some people, the idea of anesthesia, breathing tubes, hospital stays, too scary, and they end up getting radiation.
Realistically, I don't want to think about it, but you're going to put me asleep.
For surgery.
For surgery.
Right.
What you do to me while I'm asleep, I'm not going to know.
Right.
So, I mean, the idea of sticking a tube down my throat, no, it doesn't sound like something I'm going to wake up in the morning and say, oh, I'd like to have a tube in my throat.
Right.
But you're going to make it as painless as possible by putting me out.
Right.
Okay. I don't know how a patient would say, I'd rather be cut or I'd rather be nuked.
Yeah. It's a lot of shades of gray. So for some people, they have like an innate desire when they hear that word cancer that surgery is the
just get it
like
out.
Big bright flashing lights. And I think that it's a lot about you know, getting rid of that anxiety that something inside is wrong. And I think that's one reason to choose surgery when they're kind of even Steven, surgery versus radiation. It's not that often that patients can go both ways. It's usually kind of one or the other, and trying to figure out what the best option is. It usually becomes pretty clear when we start thinking about lung cancer happens a lot in patients that are unfortunately very ill from other things. And so a lot of times for them, it's not safe to put them to sleep and to put a breathing tube in and to take out a piece of a lung that's already not functioning very well. And so a lot of times it's not so much, you know, A versus B, choose one. A lot of times it's A is clearly the right choice or B is clearly the right choice.
We're fortunate here to have an incredible medical staff who are given top-notch tools and access to the Brigham and Dana-Farber's infrastructure and information. But shouldn't patients question? I mean, you go to one person and John says, cut it out. Should I just say, well, he's a nice guy, I'll trust him?
No, I'm a big fan of second opinions, whether it's from somebody within your own discipline or someone from an outside discipline. So like I kind of said when we first chatted, once you embark on a treatment, you can't put it back in. You know, you can't, once you do surgery, you can't take it back. Once you do radiation, you can't take it back. The most important thing in the early decision-making process part for patients is to go meet everybody. And if you come and meet me and we don't click, go meet another radiation oncologist. You know, a lot of the doctor-patient relationship is about finding that common ground, finding that comfort level and trust. And I think sometimes patients get, you know, they meet a doctor, they don't click, and so they pick a different treatment just because of that. I think that the best thing you can do, the best way you can advocate for yourself is to get as much information as you possibly can before you make that first treatment decision.
But it sounds like no matter what, you ought to include the guy with the knife, the guy with the chemicals, and the nuke.
Even if it's just to hear, I get referrals all the time that are just for me to say, you know, radiation isn't the right choice. Like, I love to use radiation. I think it is one of our best tools we have in our war against cancer. But it's not the right choice for everybody. And sometimes it's really important for someone just to come see me and hear that, and to hear that, you know, we've looked at everything and this is other option is a better option.
Okay, it's spread. There's spots lighting up all over the place.
Right.
I can't go hit it with my nuke everywhere.
Right.
So go talk to the guy with the drugs.
Yeah. No, that's a common occurrence. Sometimes in that situation we do radiate the troublemaker spots, but then hope that chemotherapy or immunotherapy or targeted therapy will take care of the others or keep them at bay for as long as possible. But no, that's exactly right. We can't radiate everywhere. So we oftentimes see patients just to assure them that the treatment course that they're on is the right one.
Now, what made you go into this field?
Oh, that's a tricky question. So I think I always was going to be an oncologist. We all kind of have those formative years in our lives. I think that For me, when I was probably, I was 15 to 17, one of my classmates was diagnosed with a type of pediatric tumor. My grandfather was diagnosed with prostate cancer. And one of my teachers that I was very close to was diagnosed with breast cancer, all within about a 1-year span. All three of them.
I don't think I'd want to be your friend.
Well, it's, that's how these things kind of come in runs sometimes. All three of them ultimately died of their disease within the next few years before I graduated from high school. So I think when I went to medical school, I knew that taking care of cancer patients was what I wanted to do. I don't think I realized then that that's probably 300 different jobs that you can do that with. And so in medical school, I kind of sampled a little bit of everything. Now, my background is in computer science, and what radiation oncology does, I spend most of my days face-to-face with patients. So sometimes people hear a radiation oncologist, they think I'm like in a dark room somewhere, and that's not the case. Today, I probably spent 4 or 5 hours just counseling patients one-on-one or with their families. And so radiation oncology, what it was for me was that blend. So I get to use these toys that nobody else has, because we have the best toys. And we get to do it in a way that is extremely effective and high value for patients, but we also get a lot of time with our patients. We get to spend a lot of time getting to know them during their treatment, because when you're on a radiation oncology treatment course and you're coming to us for 1 week, 5 weeks, 8 weeks, we meet with you every week. That's very unique. There are not very many times in your life where you meet.
The poor PCPs get 14.3 minutes and they got to move on.
Once a year. Yeah. And that's just the unfortunate nature of how things are sometimes. But when you're getting radiation, you meet with us every single week, and it gives you an opportunity to take care of people when they're sick, but it also gives you an opportunity to really get to know them, to really get to know what else is going on in their life. How does this fit into everything else they have going on? And it's really helped us adapt how we practice. We have social workers on site to help people navigate all the complex issues that I don't know how to navigate. Things like figuring out how to do your disability insurance, things like figuring out how to get rides to and from the center. We have a person that's just dedicated to figuring those things out for patients. And that's what I mean by there are a lot of different ways to take care of cancer patients. It's not just the doctors.
Well, I went through cancer treatment with my mother. Mm-hmm. She went in for her normal checkup, and they gave us a call and said, we can do all the tests, but in our experience, I'm giving you an 80% chance she's got intestinal cancer.
Yeah.
And she went through the treatment here in Milford. Thank God we have it, because it was so much easier.
Yeah.
Now, I mean, my darling bride and I are fortunate that, whatever time we needed, we would take it off.
Right.
But I saw the effect on her, driving her 2 miles.
Yeah.
And she would meet Dr. Mona. It wasn't Dr. Kadis, it was
Right.
Dr. Mona. To this day, 13 years later when she goes for her checkup, I gotta go see Dr. Mona.
Right.
But it took the tension out of the anticipation of being in a car for 2 hours.
Absolutely.
And it just seemed like compliance was that much easier
Yeah.
for her, but also for us. And like I say, we're fortunate because if I have to take the afternoon off every third day, I just do.
Yeah.
But not everybody is lucky that they can just take time that much time out.
Yeah, it's if we had it our way, we would have even more centers. Just because even here in Milford, we have patients that travel from Connecticut and Rhode Island and Western Mass to come here because they want to be treated at Dana-Farber, but it's easier to come here than it is to drive into Boston. So we often are kind of like a halfway point for a lot of people coming from long distances. So. What we try to do when we design a new center or where we put something in is we try to bring something to a place that as many people can get to it as easily as possible. And I think for the folks in Milford, you can't beat it. It's right up the road.
How do you answer the question? I mean, the state has a limited number of licenses they're going to issue for a linear accelerator.
Right.
And you say, we already got one,
Yeah.
but John wants another one.
John wants about 4 more.
Well,
but
how do you,
that's a different
how
question.
How do you justify to the state that you ought to put 2 in Milford and not 1 somewhere else?
Yeah, so one of it is just the need. This facility here, the hospital and the cancer center, it just the more things we add, the more patients we serve. We are tentatively planned when they make their meeting and decide we're going to have the nurses here for this many hours and all those things. Our radiation facility is technically supposed to be open from about 7:30 to 4:30 or 5. And we run that center from 7 to 7 or 8 p.m. most nights. So we're at about 25 or 30% over our capacity right now. So when we went to the state and asked for another machine, it was kind of a no-brainer. Being able to show that we already have the numbers to support a second machine. I think that's the key is you can make a really compelling argument that patients really love the care they get here. Patients come back with their family members get diagnosed. Patients come back when their spouses get diagnosed. And it just keeps the place is busy.
Now, I joke all the time about there's 28,000 of us that know Milford's the center of the universe, and there's about 7 billion that need educated.
Sure.
Why did you pick Milford?
It's we serve a lot of different communities through the Brigham Dana-Farber. When I came down here and met the team that was taking care of people here, most of our staff live in this area. Whether they live in Milford or one of the surrounding communities, they're local to this area. The care that they give to their neighbors is unparalleled. So being able to kind of plug and play into that and be a part of that team, you can't beat it. That's not the case everywhere, because of medicine is a big, complex, cumbersome thing. And a lot of places, the driving factor is not patient care. But that facility, the people that are there, they want to be there every day taking care of the folks here. And so, when you see that as a physician, it is very easy to just say, that's where I want to be every day.
Overall, where do you see the technology? I mean, okay, you're getting a $5 to $10 million new toy.
Sure.
Where do you see the technology going?
How many years down the road? So, what I talked about, the 5 or 10 year for radiation oncology is probably developing tools to make the radiation more and more precise. And it sounds like that...
More precise than a millimeter?
So when we give radiation, even when we're able to hit with a millimeter, there's the high dose cloud hits with a millimeter precision. There's always like an intermediate and a low dose.
Oh, okay.
We're going to be able, with newer technology, be able to pack that dose cloud in tighter and tighter and tighter. So where radiation fits into all this is that as immunotherapy and targeted therapy and all of these things that they're developing in the medical oncology world become more active against more cancers, patients are going to live longer and they're going to need more access to radiation. 15 years, 20 years,
Well, 20... you've just made Uncle Ed roll in his bed tonight saying, wait a minute, you haven't even installed the 5 to 10 million. You're already talking about we need another one.
Well, but on the long enough time horizon, 25 years, 30 years, it may be even longer than that. There's going to be a day where what we use for radiation, or if we use radiation at all, will look so different than what we're doing in 2018 that we'll look back at even at what we do now, which is nothing short of a technological miracle. And we'll say, gosh, look at those guys and how they did it back then. What were they thinking? Because that's just the nature of medicine. It just keeps marching forward. So my hope is that there's a day somewhere down the road where we don't need radiation. And so on the short time horizon, it's just going to keep getting better. It's just going to keep getting more focused, more targeting, more effective, less side effects. But on a long enough time horizon, I hope we don't have to do it.
Now, when you say
anymore.
side effects, what are typical side effects if you're hitting 1 millimeter bursts?
So for these brain and lung radiosurgery patients, for most patients, it's no side effects. There are rare side effects that happen. They're more like maybe 1 in 20 to 1 in 1,000 type side effects. But for the most part, when you're delivering radiation, even though it's a very high dose, but when you're delivering it to a small volume of tissue with extreme precision, there's not a lot of side effects.
So I don't lose all my hair and all that.
Sometimes patients lose like a coin-sized patch of hair here and there that comes back with the radiosurgery.
Tumor, quarter-size hair. Okay, yeah. I can understand that sacrifice.
But for most patients, it's amazing how easy it is. Maybe fatigue for a day or two after the treatment, but it's it is a very, very high value proposition.
Now, one of the ugly realities of life is people have to say, I love what you're talking about, but can I afford it?
Yeah.
Is that available? I mean, Milford's a blue-collar town.
Yeah.
Can the average Milfordian, they look at the new toy and all the treatment, can they afford this treatment?
Yeah, so we are fortunate to live in an era where cancer care is one of the things that insurance is extremely generous with. Our team works kind of around the clock to make sure that every patient that comes through our door, there are no surprise bills, there's no turning people away. We try to treat everyone we can, and we try to work with every insurance provider that we can to make sure that the patients that want to get treated at that facility can get treated there.
Is it generally a problem, or generally?
No. Thankfully, with the ACA, cancer care is kind of one of the mandated coverages, and so for the most part, there are things that we want to do that are new, and sometimes we run into trouble there. And we spend a lot of time on the phone with physicians that work for insurance companies.
But isn't that where you get the clinical trial approval?
So clinical trials are a little different. Most clinical trials are funded, and so a lot of times on a clinical trial, the drug is being provided by the clinical trial. That's why they get so expensive. A lot of times where insurance coverage gets tricky is when a clinical trial has finished, and they report the data from it, and it turns out it works really well, but it's June, and that information just came out in June or July, and you're trying to get it for your patients as
in August.
Right. And so there's always this sort of lag time between when something is really established as a good treatment and when the insurance, and that's where we spend a lot of time negotiating with
insurance. We could go on forever, but like I said, we started off saying every time I think the bar is as high as it'll go at the Regional Medical Center, somebody like Dr. John comes in and raises the bar, and I'm in awe once again. This is incredible what they're doing, and just absolutely fantastic that they're doing it here at the center of the universe. So thank you for what you're doing.
Thank you for having me.
And to our 6 loyal viewers, thanks for joining us, and may tomorrow night be a healthier night than tonight.
Not too long since I've been home. Been running all my life